got aqueous misdirection. Okay. So the first patient was a 47-year-old male with primary angle closure glaucoma, normal vision, and high pressures in one eye at 24 millimeters in the left eye, with 270 degrees of cynical closure in the right eye and appositional closure in the left eye. Glaucomatous cupping was present in the right eye, the left eye was fairly healthy. So he was given medical treatment followed by laser iridotomy in both eyes. Following this, the intraocular pressure in the right eye was quite high with maximum topical medical treatment. Therefore, he underwent trabeculectomy with mitomycin C. The postoperative period was uneventful except for IOPs of 24 to 28, for which the two basal releasable sutures which were applied were removed. The postoperative course was uneventful until the 6th week. At the 6th week, the patient presented with an intraocular pressure of 30 millimeters. At this time, there was an apex interrupted suture left, so the patient underwent an argon laser suture lysis and presented the next day with a flat anterior chamber, increased intraocular pressure, corneal edema, lenticulocorneal touch, patent PI, intraocular pressure of 46 millimeters. With the fundus examination did not show a choroidal hemorrhage. The vision had dropped. So the UBM showed a flat anterior chamber, as you can see here, with iridocorneal apposition and the anterior rotation of the ciliary processes. Sometimes you can see a suprachoroidal effusion, but this was not present in this patient. So the patient was treated conservatively with aqueous suppressants and cycloplegia with atropine 3 times a day and systemic acetazolamide as well. And since the patient was very symptomatic, mannitol was given. After 4 days, the visual acuity improved, the anterior chamber really deepened well, the ciliary processes, the body moved backwards, intraocular pressure came down. Unfortunately for this patient, this was the situation was maintained without any recurrence, the visual acuity improved, intraocular pressure was 22 with 2 medications, there was a formed anterior chamber, stable disc and visual fields. The second case did not do so well, however. This was a 14-year-old girl with diagnosed to have glaucoma elsewhere. She had very high pressures when she presented. Again, medication was given, maximum medications. This was the visual acuity. The right eye was in a very advanced stage of glaucoma. The left eye was a little better with 360 degree of cynical closure. As you can see, advanced glaucomatous cupping in the right eye, a little better in the left eye. UVM was done since it's a little rare to have angle closure in such a young age group, and you can see that there was a pseudo-plato iris kind of configuration with ciliary body cysts. So trabeculectomy with mitomycin C was planned for the right eye, the left eye to take care of whatever pupillary block element was there, a PI was done, and these were the pressures with medication following the treatment. So right eye surgery was done in October 2008, a phonics space flap was used. The postoperative period initially was uneventful, and the left eye surgery was done as well within a month. However, 6 weeks later, the patient presented with fairly low intraocular pressure, shallow anterior chamber with early choroidals. This responded with topical and systemic steroids, and the patient was fine with a slightly shallow anterior chamber but formed without any iridocorneal touch. And a few months later, the patient presented again with large blebs with high intraocular pressures in both eyes and shallow anterior chambers with iridocorneal touch. The fundus examination did not reveal any choroidal detachment or hemorrhage. This was the picture. You can see that the anterior chamber was flat throughout. And this was the left eye. You can see that the PI was patent. So this was the visual acuity and the UBM with the shallow anterior chamber. So medical treatment was tried here, but there was no improvement. So ultimately we decided to go in for surgery. And in this case, we planned for phacoemulsification to remove the cataract, which was slightly significant. So the cataract surgery can be a little difficult. You can use an AC maintainer if the AC is really flat. Plenty of viscoelastic cover is used, viscoat if possible, to protect the cornea. So once the phacoemulsification is complete, you implant the intraocular lens in the bag. This surgery was done by one of our vitreoretinal surgeons. So following the lens implantation, a vitrectomy has been done. It's almost a total vitrectomy in this case because quite often recurrences are common, and it's important that you remove the anterior hyaloid face because that is the one which is impermeable and causes frequent recurrences. The most important step is to create a communication between the anterior chamber and the vitreous cavity. So this was done at the end of the posterior vitrectomy. The area where the pre-existing iridotomy is present, the vitreous cutter is brought here so that you chew the anterior hyaloid, the posterior capsule, little bit of zonulotomy also, so that you get a large patent PI with a communication between the anterior chamber and the posterior segment. The similar type of procedure has been done by anterior segment surgeons as well, without having to resort to go to the posterior segment. You can make paracentesis fairly close to the pre-existing PI, put an AC maintainer in place so that you move the lens iris diaphragm backwards. This is possible in pseudophakic eyes only. Introduce a cutter here and chew up the capsular support and the anterior vitreous here. And usually the anterior chamber deepens immediately. The problem is that you have to be careful because you're fairly close to the vitreous base, and if your cutter is close to the vitreous base, you may get a retinal break at that point. So this was a post-operative picture, well-formed anterior chamber, and this was the outcome. The intraocular pressure was a little high, so needling was planned at a later date, and a similar procedure for the right eye was planned. So this is the middle segment of the eye. What happens in malignant glaucoma is that you have some kind of initiating event where the anterior chamber becomes shallow, and then you develop a celio-lenticular or a pseudophakic block with a very thickened and impermeable anterior hyaloid. The expansion of vitreous occurs when you get posterior flow of the aqueous into the vitreous cavity. So the important features to diagnose aqueous misdirection syndrome is an actual shallowing of the anterior chamber, presence of a patent PI, elevated intraocular pressure, but sometimes the intraocular pressure can be normal, and absence of suprachoroidal blood or fluid. This was a patient in which a large PI was present at the time of diagnosis of malignant glaucoma. So in this case, you can do a laser anterior hyaloidotomy. You have to go through the capsule and then hit the anterior hyaloid face. So this ASOCT picture clearly shows the vitreous which has herniated through this opening. Sometimes this vitreous can compact again and you can get a recurrence of the condition, so you can always repeat the hyaloidotomy if necessary. The anterior chamber has nicely deepened. So medical treatment is used to reduce aqueous flow into the vitreous cavity, cycloplegics to break the block, and you can use medications to dehydrate the vitreous as well. Surgical treatment is to break the anterior hyaloid face, reduce the vitreous volume, and create a communication in the periphery beyond the IOL margin between the anterior and posterior chamber by performing a pars plana vitrectomy and a hyaloidozonulectomy along with an iridotomy. The management of the fellow eye is important. You anticipate all these problems in the fellow eye and take precautions to avoid a shallow anterior chamber intraoperatively and postoperatively as well. Thank you. Do you have any questions?